Thanks for joining me today and learning about antiestrogen therapies. Today we're going to review some indications for antiestrogen therapies, review mechanisms of actions of the different antiestrogen medication classes, and understand adverse effect profiles of each class and how these relate to specific patient populations. Therapy can be used for breast cancer prevention. It's indicated in females who are over age 35 and who have an over 1.66 risk of getting breast cancer within 5 years. This is estimated with a model called the Gale model. The efficacy in using antiestrogen therapy in breast cancer prevention is that it will reduce the risk of breast cancer by 50%. So, this means that patients with a higher risk of breast cancer at baseline will have more benefit and more risk reduction from these therapies. Whereas a patient who has a 5 year risk reduction of breast cancer in 5 years of 2%, it would decrease their risk from 2% down to 1%. The typical antiestrogen therapy duration is 5 years. There are two different classes that are indicated here, your selective estrogen receptor modulators, or SERMs, and the two medications we commonly see are Tamoxifen and Raloxifene, and then our aromatase inhibitors, or AIs. And the two we typically see for this are anastrozole and exemestane. The choice of medication that you would choose for your patient really depends on whether they're pre or postmenopausal and the adverse effect profile of the medication, as well as the cost. Another indication for antiestrogen therapy is as adjuvant therapy in active breast cancer. And this is indicated in patients who have non-metastatic estrogen receptor, progesterone receptor positive breast cancer. It can sometimes also be used for palliation in patients with ER/PR positive metastatic breast cancer. Typically, the treatment duration lasts at least 5 years. The classes that are indicated here are the SERMs, and specifically tamoxifen, and the aromatase inhibitors that we would see typically are anastrozole, exemestane, and letrozole. Again, the choice of medication depends on whether or not the patient is pre or postmenopausal and the adverse effect profile. The first medication class that we're going to talk about are the SERMs. Just to briefly go over the mechanism of action, you can see that the SERMs work intracellularly to bind estrogen receptors that eventually either increase or decrease gene expression. Depending on the type of cell or receptor that the SERM is binding to, it may either have antagonistic effects, which would decrease target gene expression, or it can have agonistic effects, which would increase target gene activation. You'll see that this agonist and antagonist variability within each tissue gives each drug its unique indication and side effect profiles. So tamoxifen is used in the treatment and prevention of breast cancer. This medication can be used in pre- and postmenopausal women. Its specific SERM profile effects are that it's an antagonist at the breast tissue and an agonist at the bones, endometrium, uterus, liver, and coagulation system. Common side effects related with tamoxifen are hot flashes, arthralgias, edema, and mood changes. With tamoxifen, there's a black box warning for strokes and pulmonary embolisms, and you'll see that that's because of the agonist effect in the coagulation system. It makes it a prothrombotic agent, as well as uterine malignancies. And again, this is because of that agonist effect in the uterus. A few clinical pearls to go along with tamoxifen. It's a dose at 20 milligrams orally daily. Tamoxifen is a prodrug, and it needs to be converted to its active formulation. So with that, it's really important to pay attention to drug interactions, and we want to avoid it with CYP2D6 and CYP3A4 and CYP2C9 inducers and inhibitors. Specifically with tamoxifen, we think of drug interactions with the SSRIs, paroxetine and fluoxetine, because these have CYP2D6 inhibitor properties. Using tamoxifen in combination with these medications could be a reason for tamoxifen failure because the patient isn't able to convert the prodrug to the active drug formulation. With the side effect profile, you tend to think menopausal effects, so those hot flashes, muscle aches and pains, signs and symptoms that you would see when patients have decreased estrogen levels in their body. Tamoxifen is the only anti-estrogen therapy that's approved for premenopausal females. And whenever a patient is started on tamoxifen, it's really important to educate them on the signs and symptoms of blood clots. So you would include education points on stroke and DBT. Raloxifene is the second SERM that's indicated in the prevention of breast cancer and also osteoporosis. This medication can only be given to postmenopausal women. Its specific SERM profile effects are that it's an antagonist at the breast tissue and the uterus, and an agonist at the bones and on the lipid profile. Common side effects are similar to tamoxifen, but not quite as extreme. It also does have some potential for VTE events and uterine malignancies, but is less so than tamoxifen. Our second medication class that we're going to talk about today are aromatase inhibitors. First, I'll briefly touch on the mechanism of action. You'll see from the picture here that aromatase is the enzyme that is responsible for converting androgens and testosterone in the body to estradiol and therefore the active forms of estrogen in the body. When we inhibit this aromatase enzyme, then we essentially inhibit the conversion to estrogen. Aromatase inhibitors are indicated for the treatment and prevention of breast cancer. These can only be used in postmenopausal women. Effects of aromatase inhibitors are that they irreversibly bind the aromatase enzyme. This prevents the conversion of androgens to estrogen in the periphery. The reason that we can't use this class of medication in premenopausal women is because it doesn't prevent estrogens from forming in the ovaries. So patients still have a significant amount of premenopausal patients still have a significant amount of estrogen in their bodies that's coming from the ovaries. Common side effects with aromatase inhibitors include hot flashes and arthralgias. And some issues to consider with aromatase inhibitors are that they can cause elevated cholesterol levels and they can actually worsen osteoporosis by decreasing bone mineral density. There are some clinical pearls that go along with aromatase inhibitors. First is that they are sometimes used off-label in endometrial and uterine cancers. You can contrast that to the SERMs, which can sometimes cause uterine cancers. Anastrozole, which is a specific aromatase inhibitor, is one that's in the non-steroidal class, and the dose is 1 milligram orally daily. Exemestane, on the other hand, is an aromatase inhibitor in the steroidal class. The dose is 25 milligrams orally per day, and this medication specifically you have to take after a meal, preferably not a high-fat meal, because that can increase the absorption too much and cause adverse effects.